Hello everyone, welcome to 5 Mark Short Note series. Today we will discuss about status epilepticus. Status epilepticus is a neurological emergency defined as continuous or recurrent seizure lasting more than 5 minutes without recovery of consciousness. It leads to neuronal injury, systemic complications, and requires urgent medical intervention. So the incidence is 20 to 40 cases per 1 lakh population per year, common in children and elderly. Mortality is 10 to 30% depending upon the etiology and delay in initiation of treatment. Higher rates in LMIC due to infections and poor access to care. Missed or abrupt withdrawal anti-epileptic drugs, CNS infections like meningitis, encephalitis, stroke, trauma, tumors, metabolic causes like hypoglycemia, hyponatremia, hypocalcemia, alcohol withdrawal and drug toxicity, and febrile seizures in children. Imbalance between excitatory and inhibitory neurotransmission results in seizures. This will result in continuous neuronal firing and lead to metabolic stress, lactic acidosis, and cerebral edema. Prolonged seizure thereby leads to irreversible neuronal damage. So there will be repetitive convulsions without regaining consciousness. Duration will be greater than 5 minutes, may present with frothing, tongue bite, urinary incontinence, and there will be history of fever, infection, trauma, or missed anti-epileptic drug doses. In the clinical examination, there will be presentation with unconsciousness, tonic-clonic activity, cyanosis, tachycardia, and hyperthermia will be present. Fixed gaze, extensor plantar reflex will be there, and signs of underlying causes like meningitis, hepatic failure, and dehydration will also be present. What are all the differential diagnoses? Psychogenic non-epileptic seizures, tetanus, eclampsia, hypoglycemic coma, drug withdrawal or intoxication, and post-stroke rigidity. Coming to the immediate management ABCD approach, so ensuring airway patency in lateral position, give 100% oxygen for breathing, IV access, monitor BP, pulse, and ECG to ensure circulation is perfect, and begin anti-seizure therapy immediately. So stepwise drug management. The first line drug includes a lorazepam and diazepam should be initiated within 0 to 10 minutes with the dose of 0.1 mg per kg IV, maximum of 4 mg of lorazepam and 0.2 mg per kg of diazepam, maximum of 10 kg. The second line drugs include phenytoin and valproate initiated within 10 to 30 minutes, and refractive phase where there is more than 30 minutes of stroke, then midazolam, propofol or phenobarbital are indicated. Continuous IV infusion under ICU care is indicated. So the investigations include CBC, electrolytes, glucose, renal and liver function test, serum AED level monitoring should be there, CSF analysis if infection is suspected, CT or MRI brain for structural causes, and EEG to monitor the ongoing seizure activity. Coming to the prevention, strict adherence to anti-epileptic medications, avoiding abrupt drug withdrawal, early treatment of CNS infection and metabolic disorders, perinatal care to prevent hypoxic brain injury, and education of patients and families for early hospital referral in case of status epilepticus or seizures lasting for more than 5 minutes without any presence of consciousness. Prognosis will be good if treated within 30 minutes, and long-term complications include cognitive decline and motor deficits. Coming to the management, identify seizure if it is there within less than 5 minutes, ABCD stabilization, administration of benzodiazepine, load with long-acting anti-epileptic drug, IC admission if refractory, that is more than 30 minutes of seizure, treat the underlying cause and constant monitoring of EEG. To summarize, status epilepticus is a continuous seizure greater than 5 minutes, early airway management and benzodiazepine are life-saving, identify and treat the underlying cause, prevention through compliance and infection control are required. I hope you learnt from this presentation. Thank you.